practicing street medicine at times is much like doing a mission trip in a third world country, particularly in areas where people don't have health insurance, where they are concerned about seeking health care. There's a lot of healthcare trauma related to poverty and homelessness. We don't bill for services because of our volunteer makeup of our work does not allow for you to bill. So finding ways to make sure that the work that we're doing is supported.
KK, good morning and welcome to Grow Healthy, Help People, the podcast that Accordis puts out for nonprofit leaders. You're in Kansas City working with Care Beyond the Boulevard, and I'm glad to have you this morning. How's the morning going in Kansas City?
Thanks for having me, and it's a good morning in Kansas City. We're getting ready for spring, so we're good.
That's delightful. So which side of Kansas City are you on? Are you on the Kansas side or the Missouri side?
Like right now?
Yeah.
So right now I'm on the Kansas side. I live on the Missouri side. Most of our work is actually done on the Missouri side.
Okay.
So it's, if you know Kansas City, you'll be in Kansas and in a minute you'll be in Missouri and vice versa. So I just say I live and work in Kansas City because that's what I do.
Because everybody knows where that general area is, right? Everybody knows where Kansas City is. You're good enough.
Yeah, I mean, it's funny though, like a lot of people don't realize that sometimes people don't realize there's a Kansas City, Kansas, and some people don't realize there's a Kansas City, Missouri, and there's a huge issue between the two. Like they've got beef, and
really,
not not everybody's like, oh, it doesn't matter. Like some people are like, I'm not from Kansas City, Kansas, or I'm not from Kansas City, Missouri. Like it really offends people sometimes. Yeah,
okay.
It's a thing.
That's great. So tell me a little bit about your story before we get into the Care Beyond the Boulevard. What is your story? How did you get into this nonprofit world? What led you from growing up to somewhere along the way you chose a career path? Did that got you to something, and now you're here in this nonprofit world?
Complete accident, right? So I'm originally from Western Kansas, a really small town in Western Kansas, and I became a nurse right out of high school, really because I got married young and there weren't a lot of educational opportunities, but one of the things that they had is we had a community college from a ways away had a satellite site there. So became a nurse, ended up after a divorce moving to Kansas City for more opportunities for myself and my children, and worked around the metro for a long time, went back to school to become a nurse practitioner. And I think that nonprofit work was never on my radar. Ever on my radar. When I met my current husband, he was volunteering at a soup kitchen. Had never stepped foot in a soup kitchen, fortunately for me, for any reason, and was volunteering. And in doing that volunteer work, I recognized that there was a vast lack of health care for people who were living in poverty, who were experiencing homelessness. And that's kind of how I fell into the nonprofit sector. Completely not planned. When I got out of nurse practitioner school, my first job was a trauma nurse practitioner at a major healthcare system in Kansas City. Thought that was my dream job, but realized that it was a great job, not really where I wanted to be.
So you've been in the help people industry for a long time. Nurse, then nurse practitioner, and then soup kitchen volunteering. And then what prompted you to make the jump to, okay, I'm going to change not just my volunteer time, but my career and my full-time focus to nonprofit work?
Yeah. So while I was volunteering in the soup kitchen, people kept coming to me with health questions because they knew, at the time I was still in NP school, they knew I was in NP school, they knew I was a nurse, and they had learned to trust me, both the volunteers and the people coming through, which is huge when you're talking about healthcare for the homeless. Yeah. And I recognized people would be like, oh, they need their blood pressure medicines. I'm like, just go to their doctor, right? I mean, but started doing a little research, and I realized that it's not that easy when you are living on the streets, when you're living in poverty, when you don't have Medicaid, when you don't have health insurance. And so I in doing this, I said, I really want to just start a clinic. So when I got out of NP school, I was working as a trauma nurse practitioner, but this was already on my radar because I had started doing a little research, and I was like, when I get out of school, I'm going to start a little clinic in this soup kitchen so that people have access. Well, that little clinic then led to street medicine and the whole street medicine concept as a field of medicine for me. And so I said, more than just that clinic in the soup kitchen, I want to start a street medicine team in Kansas City because we didn't have one.
Okay, can I stop you there?
Yep.
I have no idea what street medicine is. So
Yeah.
fill me in and fill the others that are watching this podcast in on what is street medicine?
So street medicine is literally taking healthcare to the streets, going into encampments, under bridges, to the places where people who are experiencing homelessness live. Instead of expecting people to come to us in our clinic settings, we go to them. Literally go to the people.
Like,
Now,
hey, is somebody in this tent? Hey, under the bridge. Hey, can you come down here? And is there anything you need help with medically? Is that right? Just
that's
asking them.
exactly what we do. So healthcare providers, so I'm a nurse practitioner, physicians, nurse practitioners, go into encampments. Hey, street medicine. We usually, when we walk into encampments, number one, just as a safety, we never go alone. Number two, we don't go into encampments that we haven't been to or haven't been invited to. That's like somebody walking into your open house. If they're out in an open field, then we'll walk around. If people tell us to go away, we go away. We respect that. We have a really good reputation, as most street medicine teams do in the world, and we've earned the right to go into people's spaces with those invitations. But, walk by a tent, say, hey, is it street medicine, healthcare, does anybody need anything? If they say no, we walk on. If they say, hey, yeah, can you check my blood pressure, or I'm out of my medicine? So yeah, literally meeting people where they are.
Love it. I did not even know that was a thing. I've heard of like mission trips where you would do that instead of a clinic in a far off land, but I didn't know that was a thing in America. How many?
So it's there in the United States. Most of us in large cities live right next to areas that are third world countries. Practicing street medicine at times is much like doing a mission trip in a third world country,
Yeah.
particularly in areas where people don't have health insurance or where they are concerned about seeking health care. There's a lot of healthcare trauma related to poverty and homelessness.
Yeah.
So yeah, it is a thing. There are hundreds of street medicine teams in the United States that do exactly what we do. We're all built a little different. Like
Yeah.
every single street medicine team looks different because it's really based on the landscape, and I don't mean just the physical landscape, right?
Sure.
But the makeup of the people who are living on the streets in their area.
And street medicine is particularly for people that are homeless and are living on the streets. That is different than in poverty. That is different than struggling. You're specifically saying people that are sleeping out in the elements is who you're serving primarily.
What we call them are rough sleepers. So we're not, our street medicine is focused on rough sleepers. We're talking not about people who are in shelters, not about people who are what we call couch surfing. So couch surfing is when someone is homeless, but they're going from place to place, or maybe living in a motel for, because they can pay for it with Social Security, or a church is paying for it, or something like that. But street medicine is really focused on the rough sleepers in the United States.
Wow,
Now,
I did not know that term. I'm learning
Yeah.
so much here, KK. This is great.
That's awesome.
Great.
Now, we are a hybrid street medicine team, right? So then let's take it a little further. So we do street rounds, but then we also have clinics in places and spaces where people who are experiencing homelessness go for other services. So we don't have a brick and mortar clinic like you would go to your doctor, right? But we have, we have clinics in a couple of churches. We have a clinic in what we call a shower house where people go to get showers. We have a clinic in something we call a beehive. We have downstairs, there's a soup kitchen, and then upstairs we provide physical health, we have dental health, we have psychiatry there, but we also have case management services, and then we invite other agencies from the community to come there and provide services such as housing, IDs, birth certificates, STI, sexually transmitted infection testing, that kind of stuff.
Wow. And how many remote areas or how many partnered organizations do you do those clinics in around the area?
So we have, we have a total of 10 clinics a week. And about 45 a month. I know that doesn't do the math, but we have a couple of clinics that are just like once a month and a couple of clinics that are every other week. So we have partners with the Downtown Council of Kansas City, with a local church, with the local shower house. with a local agency that focuses on LGBTQAI community. And then, so those are the kind of the partners that we have that we go into their spaces in our 10 clinics a week.
That's awesome. Incredible. So you had this compulsion to help. Hey, I'm a nurse practitioner. I can write the prescriptions. I can treat the people. So then you start doing, would you start with street medicine? Or like where did you go from nothing to having, I want to talk about the organizational side. You had nothing to then an organization is now set up and running it for 10 years.
Yep. So when we first started, the goal was to just be at that Monday night church where I was working the soup kitchen. And the reason I wanted to start there is because I wanted to learn a little bit more about the population that I was going to be serving before I just started going into encampments going, hey, can I come see you? I needed to earn the trust of the people because it was, this soup kitchen was very large. They serve over 1,000 meals every Monday. And so we knew that we would be able to at least get a little bit of a word out about what we did. So we did that for 6 months before we started with our first street night. And so our first street night was 6 months after our first clinic. And then we still didn't know where to go. Just because we're providing services in that soup kitchen doesn't mean we know where to go to find encampments. But we knew how to approach people. We knew the verbiage. We'd be like, hey, we were at Monday night church, and they'd be like, oh yeah, I remember hearing them talk about you. So having those connections to a place that they trust was very important. So then we started going on the streets one night a week. And so it was one night at Micah, at the church, and then one night on the streets. Now, while doing this, I was still working full-time as a trauma nurse practitioner and also working one day a week at a safety net clinic, which is for the poor and underserved as well.
Okay. And then at what point did you say, this is more than a night here, a night there. This is probably going to become a real thing and might even be my life's work, working in a nonprofit. Like, when did you make the jump and say, let's incorporate, let's file a 1023, let's set up the systems and processes to have a formal nonprofit?
Yeah. So, okay, probably within the first year of doing this, I said, hey, I want to start a nonprofit. Now, interestingly enough, one of the people who were kind of helping me, they're like, you're going to fail, don't do it. And I said, oh, okay. It was about 2 years
It sounds to me like you love a good challenge. That probably motivates you even more, right?
It still motivates me today. Sometimes I'll hear those words like, you'll fail, and I'll be like, okay. But so 2 years in, after we started doing clinics, we became a nonprofit. We filed to become a 501c3 and formed a board.
Yeah.
And started all of that. And so now back in that day, and I make it sound like it was so long ago, back in the day, right? That was 2018 when we became a nonprofit. So we started in 2016, became a 501c3 in July of 2018. Back in those days, it took like 30 days to become registered. Now I hear it takes a lot longer, so I think I flew in at the right time. Yeah. And so at that time, we had $1,000 that we had, people had donated money to us. My husband and I were paying for the fuel for our street nights. We had a bus donated to us that we needed to renovate to make it a mobile medical unit. So that's when we started working on making it more formal and becoming a nonprofit. Now, I still didn't have employees, so we were still working completely on volunteers. We depended on volunteers. And just so you know, to this day, we still have last year over 400 volunteers throughout the year. Right. So as we continued to grow and saw more of a need and kind of tried to expand our services, my board was like, KK, you need to quit your job and you need to work full time. And I said, I'm not going to do that until I have 5 years of my salary in the bank, because I wanted to make sure that we were going to be able to be sustainable. I didn't want to be an agency that came in, provided services for a short period of time, and then left again. So I actually wasn't our first employee that we hired either. I think I was the fourth or fifth. I was...
You were volunteering full-time hours, but not compensated for those hours.
Yes, right. Because... well, I had quit my job as a trauma NP and I was working full-time at safety net clinics. And so I was working full time there, and then in the evenings I was doing this, managing my staff, and doing all of the stuff associated with running a nonprofit. And then in 2021, we had a private donation, a very large private donation, which gave more than 5 years of my salary in the bank. And my board said, okay, you can quit now. So I then came to work full time in 2021 for the nonprofit.
Awesome. So tell me a little bit about the programs you run now, and then I want to talk through some challenges you've had, because it sounds like you never signed up to be like when you were like 9, you never said, I want to run a nonprofit. Like that just kind of happened. So let's talk about some of the programs, then we'll talk about what are some challenges you face. So what are the programs you guys are running now?
Okay, so we have our street team, right? So you heard me say we do 10 clinics a week. So we have 4 street rounds a week. We have 2 in the evenings, and then we have 2 during the day. That the 2 in the evenings are bigger. And those are mostly staffed by volunteers. And then during the day, we have staff members who go out, and that always includes a medical provider. We help with patient assistance for medications for people who don't have Medicaid or Medicare. So we have a pharmacist who works for us who helps get patient assistance. We have psychiatry. We have a psychiatric mental health nurse practitioner who works 2 days a week for us, and then we have a psychiatrist who works with us every other week, 1 day a week. We also have a dentist. We have an oral surgeon, and then 2 dentists who volunteer with us. Now, I want to say one thing. All of our services are completely free. We do not bill any Medicare, Medicaid, any insurance, and patients are never billed. So everything we do is completely free. In addition to that, we have our stationary clinics that we talked about. We also have case management services. We help with Medicaid applications. We do IDs and birth certificates. Now, that was one of those things, like people said, oh, you need a case manager. And I was like, no, we're just going to do healthcare. But housing is healthcare. And if people are not able to get housing, they're going to be unhealthy. And when I started doing this, I saw like people would be like, I can't get housed because I don't have an ID. And the housing agencies don't do IDs. And so that was a gap that I saw that we filled. So we also do, I think I said applications to Medicaid, mainstream benefits, food stamps. We help people connect to housing services. We don't do housing, but help connect them to housing services. We help with legal services. We help get them to court, that kind of stuff. Then we also have a computer lab at one of our clinic sites where we recently got some funding where we are able to buy computers, and people can come in and get access to medical records, to job applications, that kind of stuff. And then our big thing that we do right now is our medical respite facility. We started that 5 years ago. So medical respite is for people who are experiencing homelessness and being dismissed to the streets with post-acute medical needs, IV antibiotics, wound care, physical therapy. Then, while they're in our medical respite, we work with them on long-term housing solutions. We offer medication-assisted treatment for substance use disorder. We have a case manager who's also a peer, so she has lived experience of homelessness and substance use disorder. And she has become a certified peer support worker, and she works to get them wherever it is they want to be. In the last 3 years, over 50% of all of our patients who are dismissed from respite don't go back to the streets.
Wow, that's incredible, KK.
Yeah, and we help with transportation. So we kind of do a lot.
It sounds like whatever you do today, you'll do 5 more things a couple years from now. It
Yeah, I
sounds
mean,
like you find a need and meet it. Like when there's a need, you go, we can't accomplish our mission if these people are sleeping under a bridge every night because they're not going to be healthy. So let's help them get off the street into a home, and let's help them get the IDs they need to get off the street into a home. And let's help them get the whatever. Let's help them not even get to the streets through this medical respite facility. Like they're going to land on the streets if we don't do something here. So let's get them into a home directly from that.
Well, exactly. And so for medical respite, our people are street homeless when they come to us from hospitals. We get referrals from hospitals.
Would they come directly from the like they would walk out of the hospital and you guys would pick them up? They wouldn't spend 2 nights in the street.
Well, ideally they wouldn't. Now, once in a while, we'll find someone who's been dismissed to the streets with open wounds and we'll put them in our respite, like if our street team or something like that. But the hospitals call us, the case managers call us, and they arrange transportation. They arrange, like we have patients who come for IV antibiotics, they arrange all of that. And then we have full-time staff there. We have a physical therapist. There are a lot of actually medical respite facilities in the country. They all do little different levels of things. Ours is low barrier, so people can come and go. We have very few rules. They can't use substances or have substances on property. They have to be there at night, keep their area clean. But people leave, and they leave. Generally, if they leave before they're healed, it's because that they're not in a place yet in their life where they want to be somewhere else, if that makes sense. So we work with people where they are. When I say meeting them where they are, I mean physically, but I also mean emotionally and mentally. Yeah, and the programs we develop based on the needs of the people in front of us. I didn't just say, oh, I'm going to do IDs and birth certificates. No, I didn't want to do that. But it was because of what the people were telling me. It's people saying, I can't get in to see a dentist and they have broken teeth, and okay, let's get dentistry here. Or medical respite, I had no clue what it was, but I had people being dismissed to the streets with wounds that weren't healing, with wounds that you or I would have home health for or would still be in the hospital for. And so the things that we develop as a part of our core and a part of the work that we do are developed because the people in front of us need those services.
That's great. So tell me about some challenges you have. Now you're running a nonprofit. It's a growing nonprofit, and you fundraising and systems and donation processing and payroll and websites and social media and all the things land on your plate. What are the things that you find challenging now?
Okay, so now, fast forward, right, 10 years, we now have 30 employees. I never dreamt that I would have 30 employees. So I'm trained as a nurse practitioner, not a business person, right? I think that since I quit my full-time job and was able to come to Care Beyond the Boulevard full-time, we've really grown because we have that leadership here all of the time. I find it challenging. Funding is challenging, and it's not. It's not, again, we don't bill for services. We can't bill for services because of the volunteer makeup of our work does not allow CMS, which is Medicare for people who don't know. Medicare does not allow for you to bill them for services if you're using volunteer providers. So if I have a physician who's seeing a patient as a volunteer and they have Medicare, you can't bill. Well, you can't bill Medicaid and not Medicare because that's fraud. So we really don't have the ability to bill. And so finding ways to make sure that the work that we're doing is supported. I think for me, I think that as we've grown, it really weighs heavy on me. And I was literally just having this conversation with my husband this week, how I'm a nurse practitioner. If something were to happen to Care Beyond the Boulevard, I could get a job. I have 29 people depending on me for paychecks. That weighs heavy on me to make sure that I'm finding funding. I still write a lot of our grants. I do have a team now who helps write that grant. I work closely with them to write the grants, but I'm still heavily involved in grant writing. Grant management is a nightmare. Grant reporting. I think one of the biggest challenges is grant reporting. People don't understand, people don't just give you money and you're done. We recently got a very large grant from the city, and it's broken into 4 pieces, and it's very specific down to the dollar where the funding can go. And then you have to prove that. And they don't like to pay for administrative costs. Right? Like most grants will give you, if they give you $1 million, then they'll give you, 10% of that for administrative costs, which sounds like a lot, but some of the reporting is really, really difficult. So I think one of the biggest challenges has been money, and not just like bringing the money in, but managing the money and I want to make sure that we're good stewards of the money. I want to make sure that the money is going back to the people that we're serving, that I have the least amount of overhead possible in order to make sure that we're serving the people that we say that we're serving.
Yeah, that's a lot. A lot of people don't understand that. They'll see in the news, so such and such an organization received a $3 million grant, and they don't understand that money has not changed accounts yet. There's a lot of contingencies on that money, and sometimes the grants don't even get delivered. The award gets given to the state, and the money never shows up because some policy, something changed. They ran out of money, and you go, man, we didn't get any money.
We had that happen a year ago. We had a $1 million grant that was over 15 months. I got an email on a Tuesday afternoon at 4 o'clock saying as of midnight the night before, the grant had been canceled. It was a CDC grant. We still had $300,000 left on it. And those are things you budget for, right? That was in my budget plan until the end of July or June or whenever it was going, right? And so you have to shift your thought processes. The other thing is exactly right. So last year it was announced that we got $7.2 million in home ARP funds from the city. This was one of those grants that had 4 pillars, very specific. We haven't gotten any of that money yet, not because the city has done anything wrong. It takes a long time to execute those grants. And then the other thing about grants like that is people don't understand they're reimbursement grants. So you have to have that money many times up front, and then you request.
So you have to float it for 30 or 60 or 90 days to get reimbursed for the money you've already spent.
Exactly. So you have to be able to float that money. You have to be able to have the money up front, which at times, and we've had grantors who were behind. We've had grantors like
you just said, a grant got canceled. So
a grant got canceled, right?
You would have spent the money, and then they just said, "There's no more money." Like,
yeah.
What do we do?
Or if they change, like last year, the state had changed their funding. I don't know what it was, like somehow they processed their funding, they changed it. They were 6 months behind. And we're like, hello, and so you have to be prepared for those things, and you have to be willing to change. I think that's one of the big things in running a nonprofit, and not just a medical nonprofit. I think any nonprofit, you have to be willing to flex and change. The other thing that is very important to me is that when I'm doing the work and I'm writing grants and I'm looking for funding, I chase the need and not the funds. And let me explain that a little bit. So I've seen in our area that sometimes there's funding available and someone will be like, oh, I'm going to do this. I've never done it before, but I'm going to do it now. So
because there's money, why not? I'll go get the money and do whatever I need to do. Yeah.
Right. We got a lot of dental equipment donated from an agency, is not medical, but they got a big sum of money for dental, and it lasted a year, and then the money ran out, and so they didn't do dental anymore. And so I have not started any programs based on funding. Everything that we get, our medical respite, we started in 2021 doing that. We didn't get funding for medical respite until 2024, because we were already doing it. Our dental, we didn't get money for dental for 2 years after we started doing dental. So I want to make sure that we're already doing the services. Like our computer lab, we already had computers that we were using. Now, that one I did hire somebody to then be in the lab because we had more labs, but we're trying to make sure we're doing the work before we're chasing money for it, so that we have something that's sustainable long term, and it's not just dependent on $100,000 from a grant that we're getting for a year. Or if they pull the grant, can we continue? Because that grant that we got pulled, I had 2 full-time staff members who were being paid from that grant.
Yeah. That's tough. When you already had hired them, you were already paying their benefits, their everything, and then the money gets pulled. Were you able to reallocate them to another project or find funding for that same project?
So we had some funding from the Kansas City Health Department that I was not utilizing for their salaries yet. It was going to be in the background. It ended up, at first I was like, okay, this is okay, we can flex. It ended up not really hurting me until the fall, because then this was a reimbursement grant that got behind, and Then it was really difficult. This fall was hard. It was hard, and I think a part of that was because of that $300,000 that was pulled unexpectedly. At the time, I was like, "This is good. We can flex," and we've been okay since then. And I didn't have to let anybody go, but it was stressful. Like, what am I going to do, and what is my staff going to do?
That's great. So as you know, as KK was saying, most nonprofits, every nonprofit has to also become a business. They don't want to be a business. They didn't start it to be a business, but they have payroll and taxes to pay, and 990 IRS forms to file every year, and fundraising, and how do you collect donations and getting receipts out. And if you're leading a nonprofit out there and you see this podcast, Accordus, my company, we help with that. Everything from marketing to database to accounting, we can help with all those things. So like KK struggling with tracking these grants and all that type of work, those are the kind of things that we can help with. So we'd love to talk with you. At the end of this podcast, you'll see a link to our website. Also, I'll put a link to Care Beyond the Boulevard website. KK, what are ways that people could get involved in what Care Beyond the Boulevard is doing? What are things that you need that they can be a part of from wherever they live?
Yeah, so, if they're in Kansas City, we always have volunteer opportunities. We have group opportunities. If they're far away, so this year's our 10-year anniversary, and we've asked people to donate $10 a month for a year to celebrate that 10 years. And on our website, there's a little easy click donate, a recurring $10. We also have a Amazon wish list, and that we update that all the time because our needs are changing with the weather. And we live in Kansas City, and the weather changes every day. So those are ways. Or get involved with your local street medicine teams and supporting local street medicine teams. It's not just about us, it's about the humans surrounding us in our communities.
KK, it's been such a joy talking with you today. Thank you for being on the podcast today. And if I'm ever through Kansas City, I'll look you guys up and come see more of what you're doing.
Love it. And you're more than welcome to. Thanks for having me today.
Thank you.